Good morning, class. Today we'll be discussing methods of assessing the heart. As you begin your clinical rotations after fundamentals, you will be using the techniques and skills you learned today many times. You will have the privilege of listening to a lot of hearts, interviewing many patients, and hopefully making a difference in healthcare outcomes for your patients. In previous lessons, we learned how to uh, do our assessments completely from the beginning and get the nursing history. Well, today we will concentrate mainly on physical exam of the heart. The purpose of this assessment is to obtain the patient's functional status and to supplement, confirm, or maybe even refute any data we already gathered in the nursing history. The assessment will also help us to make a plan of care with a nursing diagnosis. We will also be able to recognize areas where we can teach our patients, such as disease prevention or health promotion. You can look up the slide up on the PowerPoint, number 2, and it's about what can we learn from listening to the heart. And then you will see on the next slide, the slide shows the importance of educating our patients about healthy lifestyles and preventive measures. How many lives would we be able to save if we educated all our patients on risk and management of lifestyle? The next comes up slide number 4, and it shows the anatomy of the heart. And of course, this is a refresher because you've already had A&P. The average adult's heart lies to the left of the sternum and somewhat behind it. And it doesn't lie like on a straight, even horizontal plane. It lies kind of sideways. The right atrium may extend slightly to the right sternum. And the base of the heart, which is the upper portion, and it contains the right and left atrium, and it lies kind of toward the back. And the base of the heart, you know, is an odd thing to call it because the base of your lungs are the bottom of your lungs. The posterior in the back is the base, and then, of course, in the anterior, that is the base in the front. Well, the base of the heart is the large part, and it is at the top of the heart. And at the bottom of the heart, we call that the apex. And I just want you to notice that it is the opposite from the way the lungs are. The lower portion of the heart contains the right and left ventricles, and you have already learned that, and it is referred to as the apex and points to the front or anterior direction. The apex of the left ventricle is at the midclavicular line near the fifth intercostal space, slightly below the left nipple. This is where the heart movement can most easily be observed. You don't only listen, you're going to have to observe and palpate also. And it can be palpated here. This landmark is called the PMI, or the point of maximal impulse. The area of the chest that covers the heart is called the precordium and can be expected for abnormal lifts or heaves, and you can do that easily also by looking. Um, I lost my place, y'all. This is where the heart movement can most easily be observed, the PMI, which we were already talking about. And the area of the chest that covers the heart is called the precordium and can be inspected for abnormal lifts or heaves that are produced by a really forceful cardiac action. It can be confirmed with palpation of the palm of the hand. And if the left ventricle is enlarged, the lift can be felt at the left lateral side of the apex. If the right ventricle is enlarged, however, the lift or the heave can be felt at the border of the sternum. So look at PowerPoint slide 5 and review the blood flow map that you brought in for your homework. Now, we'll go over all of that and on this PowerPoint right now. And when we go over it, you can change whatever you need to change on your homework and keep it for future reference, okay? The next PowerPoint slide is number 6, and it is a graph of heart sounds, the systole and diastole. Heart sounds are heard by auscultation. And if they are normal, the first two sounds heard will be the heart valves closing. Now, take your stethoscopes and everyone be very quiet and place the diaphragm, which you already know is the flat side, over your heart where you can hear the lub-dub. Listen for a minute. Just listen to both sounds. Then distinguish the first sound, which is S1. This is the atrioventricular valves, which are your tricuspid and your mitral valves, and they're closing as they finish filling the ventricles. The blood's already come into the atrium, and now the valves are open, and the blood is going in through the tricuspid and the mitral valve into the ventricle. And as they finish filling the ventricles, these valves will close, and you will hear the lub. Even though these two valves don't close simultaneously, really, it's close enough for the S1 to be heard as one sound. Now listen. Did you hear the lub of your first heart sound? After the ventricles empty the blood into the aorta and pulmonary arteries through the semilunar valves, which the semilunars are the aortic valve. It's inside the aorta, of course, and coming out of the left ventricle. And the pulmonic valve inside the pulmonary artery coming out of the right ventricle. You hear the second heart sound, known as S2. When these valves close, now listen to the dub. You will hear the lub, and then you will hear the dub, and you will know that the lub sound are your two atrioventricular valves closing. And then when you hear the dub, you'll remember that these are the aortic valve and the pulmonic valve closing. So put your stethoscope to your heart and listen. Okay, did you notice that S2 has a higher pitch than S1, which is low? S1 is low and kind of dull. Listen again and listen for the different pitch of the lub and the dub. These heart sounds can be heard anywhere over the precordial area, but are heard the best mostly at the anatomic sites, which we will listen to after lecture on our volunteer patient. Each site is associated with a closure of a heart valve, and associated with these heart valves is a systole and diastole. When the ventricles contract, that produces the pressure of systole, your top number in your blood pressure measurement. And you've already been over this on systole and diastole and what it stands for. Well, you know that the pressure from systole is the pressure that pumps the blood throughout the body. So when you hear these heart sounds, you will recognize that they go with systole and diastole. When the ventricles contract, that produces the pressure of systole, your top number. It begins at S1 as the tricuspid and mitral valves open and bring the blood into the ventricles, and as they are closing, and ends at S2 when the aortic and pulmonic valves are closing. Diastole is the resting period of the ventricles. So after they contract, the ventricles then rest. That's your bottom number. That's your diastole. That is the resting pressure, and ends with S1. Sometimes you can hear a third or fourth sound. S3 is low and best heard at the apex with the bell portion of your stethoscope, and it occurs right after S2, in other words, right after lub-dub. And it sounds like Kentucky, hearing S1, S2, and then S3. S3 can be normal in children, especially young children and young adults, but it may indicate heart failure in older people. And S3 can be normal for some athletes, okay? The S4 sound is heard right before the S1. So instead of hearing lub-dub, you're going to hear D-lub-dub, D-lub-dub, or Tennessee, Tennessee. That's S4, S1, and S2. Other sounds may include murmurs, clicks, or rubs, and they can be caused by different things. like blood flow problems or valve problems. Don't be afraid to say what you hear. After years of listening to hearts, I still get excited to hear a murmur or an extra sound that I can discuss with a physician. Extra sounds and murmurs and S3 and S4 are not easy to hear. And since the inventions of echocardiograms and all kinds of different machines where we can see what's going on in the heart, almost 3D, these sounds are not heard a lot, but they're looked for. Now, this slide number 7, recognizes your patient positions, which we've been over in fundamentals. Position the patient sitting or semi-reclining in a comfortable position to listen to his heart. It's important to prepare your patient for the exam. Make the patient comfortable. Let him know that this is very private. HIPAA laws do not let anyone else come in unless the patient wants them to come in, nor does anyone in the hallway overhear what you're doing or see you or what you are saying because of HIPAA laws. And sometimes your patients want to be very private, and also they can be very modest, and we can all understand that. And a drape can be appropriate for the cover, and even a gown and a drape. Ask the patient how he or she would like to be addressed, if they want a family member present for the exam. You know, some cultural aspects may exist that the nurse doesn't know anything about. Be sure to clarify. Some people do not want anybody but their husband in there, and he has to be in there just because it's their culture. And some may want a family member in there. And if language is a barrier, be sure to get an interpreter. You don't want it to be a family member. You want it to be an interpreter that can state exactly what it is. Note any visual hearing problems the patient may have, even physical impairments. Some of your older patients have a hard time getting up on the table. They have a hard time moving around. So make sure that you notice that they are comfortable and you make them comfortable. Regard the frailty of your older patients. A lot of older patients are so frail, and don't tire them out. Uh, be cognizant of what's going on with your patient. For this assessment, we will be requiring 2 positions, the sitting patient and the supine patient, and the room should be warm. Uh, you'll have gloves on, but your hands should be warm. For this class, we'll be using the techniques of inspection or observation. We will be using palpation, and we will be using auscultation, and we'll be doing it in that order. One of the essentials of the baccalaureate prepared nurse is addressing the patient's lifestyle and genetic factors to promote health care and prevention throughout the lifespan. Address the following issues with your patient. Family history of heart disease. What age was the family member? And we're talking immediate family members, first degree members of your family. What age were they diagnosed? And if they are already deceased, what age did the family member die? This is all very important. Anyone with high cholesterol levels in your family, high blood pressure, a stroke, obesity, or congenital heart disease, arterial disease, or rheumatic fever. You need the patient's past medical history. Any of the following: rheumatic fever, heart attack, heart murmur, varicosities, heart failure, any present symptoms that are associated with heart disease, fatigue, shortness of breath, dyspnea. How many pillows do they use at night? Do they have to prop up to sleep? Called orthopnea. Edema. Do they have fluid in their legs? Do they cough? Do they have chest pain? Do they have palpitations? Have they had syncope episodes or near fainting episodes? Either one. Do they suffer from hypertension, wheezing, uh, blood in their sputum, which is called hemoptysis? Any presence of diseases that can adversely affect the heart, obesity being one that runs in families, uh, diabetes, lung diseases, or endocrine disorders. Ask about these lifestyle habits too. Ask about smoking, and not just about smoking. Do they use any tobacco product? What is their alcohol intake? Do they have any substance abuse issues? And not just illegal street drugs, y'all. You have to consider um, people misuse prescription medications too. What about eating and exercise? What are their eating habits like? Do they eat nutritious diets? Do they get regular exercise? And what is their stress level? Like maybe in their job or in their marriage, whatever. What is their stress level? It has a lot to do with a person's lifestyle. Have the patient lie supine to examine anatomic sites of the precordium. And now we're going to be on slide 8, so y'all can watch slide 8. Locate the angle of Lewis. It's at the top of the sternum, and it's an angle, and you can see it very plainly, and you can feel it very plainly. And underneath the second rib, which is right at the angle of sternum, is the second intercostal space on both sides of the sternum. And to the right side, the best listening area for the aortic valve will be where you will auscultate, and to the left side is the pulmonic area where you will auscultate. From the pulmonic area, move down with your fingertip 3 intercostal spaces, where you will be at the 5th intercostal space on the left of the sternum. Here you will locate the tricuspid valve. And of course, the tricuspid valve is between the right atrium and right ventricle. From the tricuspid valve, move your fingertip laterally 2 to 3 inches to the left, which will be almost the midclavicular line, and you will reach the apical or the mitral valve area. And of course, the mitral valve area goes between your left atrium and your left ventriculum. So you can also notice the point of maximal impulse here also. And note, the patient may need to be repositioned to the left lateral recumbent position to get the best PMI. Inspect and palpate these anatomic sites and note any pulsations which would be an abnormal finding and may indicate enlargement of the ventricle being examined. So see, you can palpate this too. And if you get down and you look across the precordium, if there's anything like that you observe in this area, then you note that also, because you don't want any lifts or heaves either. Now inspect and palpate these sites and notice any pulsations, okay? And if the apical location is displaced, note the distance between the apex and the mid-clavicular line in centimeters, which probably as new nurses, it'll be hard to do. But as you nurse and the longer you nurse, you'll be able to do this. Now you can perform auscultation. Now you're going to have the patient at a 15 to a 45 degree angle. So you can bring him up and make sure that he's draped from the waist down, and make sure the room is quiet because heart sounds are low and any outside noises can impede your exam. Make sure the room is quiet, very quiet, using the same anatomical landmarks as used for palpation and observation. Listen to both S1 and S2. Concentrate on both sounds individually. The first heart sound, S1, followed by systole. The second heart sound, S2, followed by diastole. Repeat the exam with the patient sitting in an upright position because some sounds are heard easier in different positions. So you can listen to both positions. You can listen to the 15 to 45 degree angle, whichever angle is more comfortable for your patient, and then listen to the upright 90 degree. If your heart rate is not normal, if it's not between 60 and 90 beats a minute, it's not going to be easy. And so the anatomic sites, if the heart rate is normal, 60 to 90 beats a minute, you will be able to hear it better. Abnormalities may include increased or decreased intensity, either one, with beats or sharp sounding clicks. And as stated before, S3 can be normal in children and young adults, but it can be abnormal in older people. And S4 in older adults can be an indication of hypertension. The table up on the PowerPoint slide number 9 can help you distinguish normal and abnormal heart sounds. And you will see by the slide and how the slide is covered here that S1 just says what we already said. It's dull, low, and pitched as the lub. And the intensity in the aortic valve is less than S2, and in the pulmonic valve, it is also less intense than S2. But when you get over to the tricuspid and the mitral valve, then S1 is louder or equal to. And same in the tricuspid and the mitral valve, it's louder than or equal to the sound of S2 in intensity. And of course, the description of systole, it's normally a silent interval, and it's between S1 and S2. And then you come to the S2 sound. Now, it's a higher pitch than S1. It's the dub. And in the aortic area, it's louder than S1. And in the pulmonic area, it's louder than S1. And it's abnormal if it's louder than the aortic S2 in adults over 40. Now, the tricuspid valve, the S2 is less intense or equal to S1, and the same with the mitral. And then the diastole, it's normally a silent interval that you don't hear at all. And it's between S2 and S1. The demonstration that we're going to have with our volunteering students will be locating the anatomic sites and palpating, observing, and auscultating also. And I want y'all to know that we're going to take a break, and when we come back, we will put our volunteer, and we will each get to hear in the anatomic sites, listen, palpate, and observe on our patient with our stethoscope so that we can have some practice before we actually go out into clinicals in the next few weeks. And I would suggest that each and every one of you listen. If you're married, have a significant other, whatever, children, that you would start listening to heart sounds, because it will help you immensely when you get into the clinical area to know what you've heard and what you have not heard that will be normal. And thanks for your time, and y'all, your homework's on the board, and tomorrow we will see you again.